Dear panelists, ladies and gentlemen, my PhD takes a translational approach to the prevention of diabetes after acute pancreatitis and in prediabetic individuals. I'm Olga Zahariev, a UK-trained dietitian, currently working at the Division of Pancreatic Diseases. My vision is a world where preventable diabetes is prevented, and my mission is to shift health policy towards prevention and to educate patients. I will use different approaches to explore diabetes prevention. The first project aims to identify patients at risk of developing dysglycemia after acute pancreatitis. The second project is an interventional study exploring the effect of dietary fat restriction on pancreatitis recurrence and endocrine insufficiency. So the first project is identifying patients at risk of developing diabetes following acute pancreatitis. Until recently, it was believed that acute pancreatitis causes only a temporal acute imbalance in health. However, 1 in 5 patients develop diabetes within 5 years of their acute pancreatitis. Moreover, diabetes has a huge health and economic burden on society. Yet, only 3% of post-acute pancreatitis diabetes cases are diagnosed correctly. Therefore, as a first step, my project aims to identify patients at risk of developing diabetes after acute pancreatitis. We studied patients who had acute pancreatitis but no diabetes at the point of discharge. We compared various biomarkers to their absence, such as severity, necrosis, and obesity. We believed that diabetes develops significantly more frequently after acute pancreatitis that was severe, necrotic, or caused by hypertriglyceridemia. Systematic search has been carried out and identified nearly 12,600 records. After full text selection, we were able to include 45 studies in the analysis. Statistical analysis has been finished, and we have my results here. However, to briefly summarize the results, I will be showing you aggregated forest plots showing the pooled odds ratio for each of the risk factors. So if I can get this, so the pooled odds ratio is always there for each of the risk factors listed on the left. The outcome is expressed as either diabetes or impaired glucose homeostasis, which is an umbrella term including both prediabetes and diabetes. The odds ratio, when it's over 1, it will indicate that the risk of developing dysglycemia is higher in the exposed group, which is always indicated in the first column. So I will be showing you 4 figures of aggregated forest plots. On figure 1, you see the association between severity and new onset dysglycemia. You may notice that having severe or moderately severe disease is associated with a significantly increased risk of developing dysglycemia compared to a mild disease progression. Moreover, you may notice that that the association is more pronounced for impaired glucose homeostasis compared to diabetes on its own. Figure 2 shows that having local complications such as necrosis or pseudocyst formation is associated with significantly increased odds of developing dysglycemia. In terms of recurrent pancreatitis, we found a tendency of increased risk for developing dysglycemia, yet it was not of statistical significance. We are surprised by this, especially because Andre's meta-analysis has found that patients with recurrent pancreatitis are more likely to have alcoholic or hypertriglyceridemic etiology. And now I would like to explain the association between etiology and new onset dysglycemia. You may notice that we found that having alcoholic or hypertriglyceridemic etiology is associated with an increased risk of developing dysglycemia. Although it did not reach statistical significance for hypertriglyceridemia, that's likely due to the small number of studies. So there are only 3 of them that we could pull data from. So we would probably get significance if it was more data. Regarding alcoholic etiology, it's likely explained by the fact that patients with this problem have already destroyed a large proportion of their pancreas. They often struggle to quit drinking, and the majority progress on to chronic pancreatitis. So hypertriglyceridemia and alcoholic pancreatitis, these etiologies are associated with a more toxic nature and pathophysiology compared to biliary or idiopathic etiology. And figure 4, the final one, shows that we have found no statistical significance for either of the comorbidities or demographic factors shown on the figure, such as dyslipidemia, obesity, male sex, smoking, and liver disease. However, you may notice that the pooled odds ratio is always over 1, and that we have been able to include mostly only 3 studies in each of the analyses. So this study is the first comprehensive meta-analysis on this topic. We have been also able to use a robust scientific methodology with large pooled sample sizes. Yet, the included studies used different methods and time points for assessing dysglycemia. We did a subgroup analysis for follow-up time length to account for some of this heterogeneity. Moreover, another limitation is that only 33% of the studies were based on data from less than 4 studies. But we can still conclude that we have found that having severe or moderately severe disease progression, local complications, and alcoholic etiology is associated with a significantly increased risk of developing dysglycemia after acute pancreatitis. Moreover, we would conclude that we have found a tendency for increased risk for dysglycemia with a hypertriglyceridemic etiology, recurrent pancreatitis, the comorbidities of dyslipidemia, liver disease, and male sex. On the other hand, we would say that having a mild or biliary etiology or idiopathic etiology is associated with a lower risk of dysglycemia. Yet, by no means does this mean that these patients don't develop diabetes. It's only that it's much lower compared to the other risk factors. So the implication for practice is that while every patient would benefit from monitoring their glucose homeostasis after acute pancreatitis, at least patients in the high-risk group should be monitored. These patients are those who had severe or moderately severe disease progression, local complication, alcoholic or hypertriglyceridemic etiology. Future research, however, should be focusing primarily on diabetes prevention strategies, as of yet there is none in acute pancreatitis patients. I was able to showcase my data at 2 of the conferences already, and the 3rd one is going to happen in October. My manuscript drafting is nearly finished and aiming to submit to the Lancet Diabetes and Endocrinology. The 2nd project is an interventional study exploring the effect of dietary fat restriction on pancreatitis recurrence and endocrine insufficiency. Up to approximately 35% of the patients progress to chronic pancreatitis and recurrent pancreatitis. Yet, there is only preventative measures in alcoholic and biliary etiology in the form of alcohol cessation and cholecystectomy. Despite this fact, most of the patients are still advised to follow a low-fat diet without actual evidence behind it. Therefore, this project aims to conduct a randomized control trial to test the effect of dietary fat restriction after acute pancreatitis. The study will have 2 arms. One of them would be a diet consisting of 15% fat content, and the other one is consisting of 30% fat content. Patients will be asked to follow this diet for 2 long years, and they will be meeting with us 6 times to ensure compliance and to collect data. As a dietitian, me and my team have been involved in developing the intervention in the form of weekly meal plans, recipe booklets, shopping lists, and so on. Some of them are printed already. As also the trial coordinator, I was also involved in getting the approval for the modifications in the ethical approval, developing the internal protocol and training the staff, and also delivering the intervention. As of yet, 4 patients are enrolled in the study. So to summarize, my PhD will result in us being able to identify patients at risk of developing diabetes after acute pancreatitis. We also be able to determine if dietary fat content affects pancreatitis recurrence and endocrine insufficiency. I would like to close the presentation with a quote from Thomas Edison: "The doctor of the future will interest his patients in the care of the human frame, diet, and in the cause and prevention of disease." Thank you for your attention. I would like to welcome any question.
Thank you for your excellent presentation. In your first project, you mentioned that the monitoring is needed. What is your plan? How would you do that?
So currently in the Hungarian healthcare system, patients are usually discharged from hospital and they are not at all followed up. Our unit is special from the perspective that they are brought back at 1 month after their episode. However, it would be the most ideal if patients would be also checked 3 months later on, because after an acute pancreatitis, there is stress hyperglycemia in the first 3 months. There is a potential for it. And diagnosing post-pancreatitis diabetes is only possible after these 3 months. So likely they would have to go to private at the moment, but it would be ideal if that could be changed and patients would be able to use the national healthcare system.
Congratulations, very nice presentation. My question is regarding your 2nd project. Who's doing the randomization of the patients? Is it a blinded one, or you decided? Or?
So it was done by a software. We have all the data, and when the patients come in, we just have to check whether they had chronic pancreatitis or whether they have existing diabetes, and based on that, they go into the different categories. So I'm the one who sees them, but it has been predetermined by the software, which one, depending on when they come in.
But you know who is on 15% and who is on 30%?
As the dietitian doing the intervention, I would need to know, because otherwise I won't be able to tell them which foods to avoid. Therefore, it's unable to be double-blinded for sure.
Okay, thank you.
First of all, congratulations, especially for these booklets. That must be a really big work, I can imagine, as a dietitian too. So I am curious, actually, so you enrolled 4 patients, but does it mean that they started already the diet, or you just printed it and they didn't, or hasn't
So
actually?
3 of them have already started, and the first one is going to come back for their second appointment next month. So we are excited to hear how it's going to go on. And there was also a patient who unfortunately has been admitted again to a hospital before we could deliver the intervention. So he didn't have the first education yet, but the others are on the diet.
And what are the feedbacks? I'm really curious.
Well, considering none of them have been back for their second appointment yet, I would say that from the first appointments we could conclude that based on their general education, it's a little bit more challenging with certain patients to advise them, because making the difference between 15% and 30%, you sometimes need to know the labels to read them, do a little bit of calculations. So it's challenging from that perspective. It depends on the educational status, I would say.
Thank you.
Thanks.
It's a lot of patients you can talk to and try to engage them in your second project. What are the main reasons of rejection? Just curious.
Unfortunately, the reason why it's only 4 patients is because it's restricted to idiopathic etiology. This was decided based on the fact that there is already preventative measures for alcoholic and biliary etiology, and we don't really know. Those patients who have idiopathic etiology usually had lots of pancreatitis episodes. They often know even about the diets, but just it's keep recurring. So that's why we chose this group, and that's quite limiting because there is much less of those compared to the other etiologies. So that would be the main one. Also, we were looking for patients who had at least 2 pancreatitis episodes in the last 2 years, because the main outcome of the study is actually pancreatitis recurrence. So it would give us a better chance and hopefully smaller number of years to complete the study.
When you consent your patients before randomization, and when you tell them about the 2 potential diets they might have as a result of the randomization, do they say, oh yeah, I want to be on that arm? In other words, is there any patient's preference influencing the study?
No, we never take into account if they prefer one over the other, but we usually just say that one of them is a lower level of fat content, whereas the other one is the one recommended by the WHO standards, which is already a lower one compared to the general Hungarian population.